Presence with one episode of urinary tract infection. The patient responds well to treatment and urinalysis reveals E. coli as the causative organism. There is no family history of ureteric reflux or renal disease. According to NICE guidelines, what imaging test, yes, should be recommended? A. Urgent urinary tract ultrasound. B. Routine urinary tract ultrasound within 6 weeks. Center routine urinary tract ultrasound with DMSA within for 6 months. D. Routine urinary tract ultrasound, DMSA, and micturating cystourethrogram. E. Magnetic resonance cystourethrogram. 62. A 55-year test responds well to treatment within 48 hours. Atypical UTI, recurrent UTI. Ultrasound during the acute infection. No, yes, yes. Ultrasound within 6 weeks. Yes, no, no. DMSA for 6 months following the acute infection. No, yes, yes. MCUG. No, yes, yes. Chapter 12. 12. Test paper 6, answers. 346. Recommended imaging schedule for infants and children between 6 months and 3 years. Test responds well to treatment within 48 hours. Atypical UTI, recurrent UTI. Ultrasound during the acute infection, no, yes, no. Ultrasound within 6 weeks, no, no, yes. DMSA for 6 months following the acute infection, no, yes, yes. MCUG, no, no, no. Recommended imaging schedule for children 3 years or older. Test responds well to treatment within 48 hours. Atypical UTI, recurrent UTI. Ultrasound during the acute infection, no, yes, no. Ultrasound within 6 weeks, no, no, yes. DMSA for 6 months following the acute infection, no, no, yes. MCUG, no, no, no. Atypical UTI includes the following: seriously ill, poor urine flow, abdominal or bladder mass, raised creatinine, septicemia, failure to respond to treatment with suitable antibiotics within 48 hours, infection with non-E. coli organisms. Recurrent UTI includes the following: 2 or more episodes of UTI with acute pyelonephritis/upper urinary tract infection, or 1 episode of UTI with acute pyelonephritis/upper urinary tract infection plus 1 or more episode of UTI with cystitis/lower urinary tract infection, or 3 or more episodes of UTI with cystitis/lower urinary tract infection. Urinary tract infection in under 16s, diagnosis and management. Clinical guideline, CG54, published date, August 2007. https://www.nice.org.uk/guidance/CG5 accessed on February 22, 2017. 62. A. T1 Mr. Hypointense, T2 Mr. Hyperintense. 55-year-old woman is found to have an incidental, plurally based 7 cm ovoid mass with smooth tapered margins, on an otherwise unremarkable CT urography examination. MR imaging is performed for further assessment. Which of the following imaging characteristics is most suggestive of a diagnosis of benign mesothelioma? A. T1 Mr. Hypointense, T2 Mr. Hyperintense, contrast enhancement on CT avid B, T1 Mr. Hypointense, T2 Mr. Hyperintense, contrast enhancement on CT minor C, T1 Mr. Hyperintense, T2 Mr. Hyperintense, contrast enhancement on CT avid D, T1 Mr. Episode of UTI with acute pyelonephritis/upper urinary tract infection plus 1 or more episode of UTI with cystitis/lower urinary tract infection, or 3 or more episodes of UTI with cystitis/lower urinary tract infection. Urinary tract infection in under 16s, diagnosis and management. Clinical guideline, CG54, published date, August 2007. https://www.nice.org.uk/guidance/CG5 for accessed on February 22, 2017. 62. A. T1 Mr. Hypointense, T2 Mr. Hyperintense, contrast enhancement on CT. Avid benign mesothelioma is otherwise known as solitary fibrous tumor of the pleura. Unlike malignant mesothelioma, it has no recognized association with asbestos exposure. It is usually solitary and more commonly arises from the visceral pleura. It is asymptomatic in 50% and is a recognized cause of finger clubbing, hypertrophic pulmonary arthropathy, and episodic hypoglycemia. It is usually sessile but may be pedunculated, in which case shape and location may vary with the patient's position. Imaging characteristics are as above, and contrast enhancement may be heterogeneous if there is myxoid degeneration and hemorrhage. About 14%-30% undergo malignant degeneration. Surgical excision is curative. Dannert W., Radiology. Mr. Hypointense, T2 Mr. Hypointense, contrast enhancement on CT. Avid E, T1 Mr. Hyperintense, T2 Mr. Hyperintense, contrast enhancement on CT minor. 63. A patient with known ulcerative colitis is admitted as an emergency following an episode of acute abdominal pain. The clinicians are worried about toxic megacolon and request an. Chapter 11. Test paper 6, questions. 316. Abdominal radiograph. Which of the following findings on the radiograph would be most specific for toxic megacolon? Review Manual, 7th ed. Philadelphia, Pa, Lippincott, Williams and Wilkins, 2011:524. 63. D. Dilated transverse colon with mucosal islands. Toxic megacolon and perforation are major complications that account for most ulcerative colitis-related deaths. Toxic megacolon is a fulminant form of colitis where inflammation becomes transmural, and ulceration leads to neuromuscular degeneration and loss of muscle tone. Chapter 12. Test paper 6, answers. 347. The transverse colon is the least dependent part of the colon in the supine patient and therefore gas collects in this location. Dilatation occurs and perforation is likely. Radiographic findings include marked dilatation of the colon with absence of Hausstrahl markings, edema, and thickening of the colon wall, pneumatosis coli, and perforation. Barium studies should not be performed because of the risk of perforation. Brantwe, Helm C.A., Fundamentals of Diagnostic Radiology, 3rd ed. Philadelphia, Pa, Lippincott, Williams and Wilkins, 2007:856. 64. C. Inferior mesenteric. Megacolon. A. Preservation of Hausstrahl. B. Thumbprinting of the mucosal wall. C. Descending colon diameter of 4.5 centimeters. D. Dilated transverse colon with mucosal islands. E. Pseudodiverticuli in the ascending colon. 64. A 12-year-old boy undergoes ultrasound of his renal tract to investigate recurrent urinary tract infections. The kidneys initially appear to lie more inferiorly and anteriorly than would normally be expected. On closer examination, a bridge of renal tissue connects the lower poles of both kidneys, and a diagnosis of horseshoe kidney is made. What structure has limited the ascent of the horseshoe kidney, causing its abnormal location? A. Mesenteric artery. As the horseshoe kidney ascends, the isthmus comes in contact with the inferior mesenteric artery and halts it, causing the renal pelvis to lie inferior and anterior to their normal position. Horseshoe kidney is the most common renal fusion abnormality, which is seen in 1/4 per 1,000 individuals. It occurs when the two kidneys are attached in the midline by their lower poles. There is an increased risk of calculi and infection because of urinary stasis. The risk of trauma is also increased, as in compressive injuries of the abdomen the midline isthmus of the horseshoe is compressed against the spine. In addition, as the kidney is lower lying than normal, it is less protected by the thoracic cage. There is a 3 to 4 times greater risk of malignancies, including transitional cell carcinoma, Wilms, and occasionally carcinoid. Brantwe, Helms C.A., Fundamentals of Diagnostic Radiology, 3rd ed. Philadelphia, PA, Lippincott Williams and Wilkins, 2006:875. Dannert W., Radiology Review Manual, 7th ed. Philadelphia, PA, Lippincott Williams and Wilkins, 2011, 948-9. A. Umbilical ligament. B. Celiac axis. C. Inferior mesenteric artery. D. Superior mesenteric artery. E. Attachment to the dome of the bladder. 65. A plain film of the knee of a 33-year-old man involved in an RTA shows impure depression fracture involving the lateral tibial plateau. What would be the Schitzker classification? A. Type I. B. Type 2C. 65. C. Type 3. The Schitzker classification grades tibial plateau fractures in order of increasing severity based on the pattern of injury. Type I. Lateral tibial plateau. Plateau split fracture, no depression. Type 2, lateral tibial plateau split with depression, most common type 3, lateral tibial plateau pure depression only. Type 4, split and slash or depressed fracture of medial tibial plateau. Type V, fracture of both medial and lateral tibial plateau with the metaphysis still in continuity with the diaphysis. Type 6, fracture of both tibial plateau and transverse subcondylar tibial fracture with separation of the metaphysis from the diaphysis. Mark Hart. B. BK, ETAL Schitzker classification of tibial plateau fractures. C. Type 3D, Type 4E, Type V. 66. A 55-year-old postmenopausal woman is being treated with tamoxifen for breast cancer. Which of the following might occur as a side effect of this medication? A. Increased size of her uterine fibroids. B. Reduction in size of her uterine fibroids. C. Formation of multiple ovarian cysts. D. Cervical stenosis. E. Thin atrophic endometrium. Fractures, use of CT and MR imaging improves assessment. Radiographics. 2009, 29, 25, 85, 97. 66. A. Increased size of her uterine fibroids. Tamoxifen has weak estrogen agonist effects in the uterus despite working as an estrogen antagonist in the breast to treat breast cancers. Uterine fibroids are estrogen sensitive and therefore instead of regressing postmenopausally, these women may experience an increase in symptoms because of their fibroids, as many women taking hormone replacement therapy. Tamoxifen can also cause endometrial hyperplasia and an increased risk of endometrial carcinoma. Formation of multiple ovarian cysts occurs in ovarian hyperstimulation syndrome as a result of clomiphene therapy taken for infertility, and in polycystic ovary syndrome, where multiple cysts are characteristically seen around the periphery of enlarged ovaries. Dannert W. Radiology Review Manual, 7th ed. Philadelphia, PA. Endometrium. 67. 67. A 33-year-old man with chronic sinus disease is being considered for a functional endoscopic sinus surgery (FES) operation. The ENT surgeon refers him for CT sinuses prior to surgery. Regarding the ethmoidal sinuses, the ethmoidal air cells occasionally pneumatize laterally and posteriorly around the frontal recess. What is the name of this anatomical variation? A. Concha bullosa. B. Adrenaci cell. C. 67. B. Adrenaci cell. Adrenaci is a Latin term literally meaning nasal mound. At rhinoscopy, the adrenaci appears as an eminence located on the lateral nasal wall at the leading edge of the middle turbinate. It represents the intranasal portion of the frontal process of the maxilla. As noted earlier, the adrenaci serves as the anterior limit of the frontal recess. Pneumatization of the adrenaci, resulting in the so-called adrenaci cell, occurs in 78%, 98.5% of individuals. When present, adrenaci cells are considered the most anterior of all ethmoid cells and can pneumatize posteriorly to narrow the frontal recess. Coronal and sagittal reformatted CT images are most helpful in identifying the adrenaci cell. On coronal images, the adrenaci appears as a laterally placed sinus below the frontal sinus and anterior to the middle turbinate. Sagittal images demonstrate the anterior location of the air cell. Haller cells are extramural ethmoidal air cells extending to the inframedial orbital floor. Onidae cells are posterior-most ethmoidal cells which lie superlateral to the sphenoid sinus in close relation to the optic nerve and internal carotid artery. Huangbai, ETAL failed endoscopic sinus surgery, spectrum of CT findings in the frontal recess. Radiographics. 2009, 29:17795. 68. C. Haller cell. D. Onidae cell. E. Paradox middle turbinate. 68. A 40-year-old man presents with dyspnea and peripheral edema and is found to have elevated jugular venous pressure. Echocardiography shows reduced mobility of the pericardium. Contrast-enhanced CT is performed. Which of the following features is least suggestive of a diagnosis of constrictive pericarditis? A. Pleural effusion. B. Contrast reflux into the coronary sinus. C. Curvature of the interventricular septum to the right. Chapter 11. C. Curvature of the interventricular septum to the right. Constrictive pericarditis is most common in men aged 30-50 years. It most commonly occurs following cardiac surgery, although it is often idiopathic, with other etiologies including viruses such as Coxsackie B, tuberculosis, and uremia. The computed tomography scan may show a normal-sized heart with superior vena cava, inferior vena cava, and azygous vein dilatation. There is flattening of the right ventricle and curvature of the interventricular septum to the left, rather than to the right, because of high right ventricular filling pressures. Pericardial thickening and calcification is a feature, as are pleural effusions. Treatment involves surgical stripping of the pericardium. If untreated, protein-losing enteropathy may occur as a result of raised inferior vena cava and portal venous pressures. Dannert W. Radiology Review Manual. D. Linear pericardial calcifications. E. Azygous vein dilatation. 69. A 65-year-old woman with known history of gallstones is referred for an out-of-hours ultrasound scan to investigate fever, rigors, and deranged liver function tests. Ultrasound demonstrates a common bile duct measuring 11 mm diameter and mild intrahepatic biliary dilatation, and a gallbladder containing multiple calculi associated with wall thickening, pericholecystic free fluid, and a positive Murphy sign. What diagnosis should be fed back to the referring clinicians? A. Ascending cholangitis. B. Biliary colic. C. Acute cholecystitis. D. Primary sclerosing cholangitis. E. Impacted calculus in common bile duct. Manual, 7th ed. Philadelphia, Pa, Lippincott, Williams and Wilkins, 2011:641. 69. A. Ascending cholangitis. The overwhelmingly important diagnosis not to be missed in this scenario is ascending cholangitis. This is because ascending cholangitis needs immediate treatment with broad-spectrum antibiotics and biliary drainage via either cholecystectomy or acute laparoscopic cholecystectomy. Although a sonographic positive Murphy sign and pericholecystic free fluid suggest a diagnosis of acute cholecystitis, this should not distract the clinician from the presence of cholangitis, which is confirmed by the presence of fever and jaundice and is primarily a clinical diagnosis rather than a radiological one. Acute cholecystitis is not a clinical emergency, and in this case, is an associated finding that likely predates ascending cholangitis. Dannert W. Radiology Review Manual, 7th ed. Philadelphia, Pa, Lippincott, Williams and Wilkins, 2011:71011. 70. C. Histiocytic response. Duct. 70. A 65-year-old woman presents to the orthopedic clinic with left hip pain 3 years following a total hip joint replacement, THR. The plain radiograph shows focal radiolucencies around the prosthesis with smooth endostele scalloping. The patient is systemically well with normal inflammatory markers. Presentation and radiographic appearances are characteristic of which of the following? A. Mechanical loosening. B. Infection. C. Histiocytic response. D. Stress shielding. E. Heterotopic ossification. 71. An X-ray of the mandible. Response describes a macrophage reaction to any component of the arthroplasty, e.g. metal, cement, plastic spacer. The condition tends to occur within 1-5 years after surgery, and the characteristic radiographic finding is smooth endostele scalloping. There is an increased risk of fracture through the affected bone, and therefore close follow-up is required. Computed tomography may show a soft tissue component, and appearances can be aggressive. Stress shielding refers to areas of lucency often in the femur following THR secondary to alterations in bone loading. It predisposes the patient to both periprosthetic fractures and loosening, and is more common in uncemented prostheses. Kia CF, Monk PL, GR, Chan LP. Mandible demonstrates a well-defined, unilocular cyst with corticact margins at the ramus. The patient is known to have a history of multiple skin lesions. What is the most likely diagnosis? A. Radicular cyst. B. Residual cyst. C. Cementoma. D. Odontogenic keratocyst. E. Ameloblastoma. 71. D. Odontogenic keratocyst. Odontogenic keratocysts, OKC, are most commonly located in the body or ramus of the mandible. Most OKCs possess destructive potential, with a high recurrence rate after resection. OKCs develop from the dental lamina, which is found throughout the jaw and overlying alveolar mucosa, and is lined by stratified keratinizing squamous epithelium. Thus, the cysts can occur throughout periapical or primordial regions. Unlike follicular cysts, OKCs can expand cortical bone and erode the cortex. Fortunately, malignant transformation of these lesions is rare. The lesion is multiloculated, often with daughter cysts that extend to the surrounding bone. Multiple OKCs in a young patient should raise the possibility of basal cell nevus syndrome, Gorlin-Gold syndrome. Associated findings with this autosomal dominant disorder include midface hypoplasia, frontal bossing and prognatism, mental retardation and calcification of the falx cerebri. Dunphy. C. Cementoma. D. Odontogenic keratocyst. E. Ameloblastoma. 72. A tibia and fibula radiograph is performed on a 2-month-old baby for leg swelling. The radiologist notices fine periosteal reaction along the diaphysis of the tibia. Which one of the following statements is false regarding neonatal periosteal reaction? A. Physiological periosteal reaction may be a normal finding in children up to the age of 6 months. B. Commonly encountered sites of physiological periosteal reaction may include the humerus, tibia, and femur. C. If physiological periosteal reaction is present, it is typically asymmetric. D. The initial presentation of non-accidental injury may include periosteal reaction of a long bone. E. The presence of marked periosteal reaction may suggest an underlying congenital cardiac disease. Dunphy BL, ETAL. Of the falx cerebri. Dunphy BL, ETAL radiologic and pathologic characteristics of benign and malignant lesions of the mandible. Radiographics. 2006, 26:175168. 72. C. If physiological periosteal reaction is present, it is typically asymmetric. Periosteal bone formation may be due to either physiologic or pathologic causes. Physiological periosteal new bone formation is seen in up to a third of infants during the first few months of life. They are benign, usually symmetric, and involve the long bones, femur, tibia, and humerus. Radiographs demonstrate one or more dense lines of periosteal reaction along the diaphyses. Pathologic bone formation generally results from an adjacent inflammatory process or a hypoxic or toxic stimulus. Common causes of pathologic periosteal reaction in children include trauma to the underlying bone. However, other causes such as hypervitaminosis A, prostaglandin therapy, cortical hyperestosis, Caffey's disease, hypertrophic osteoarthropathy, primary and secondary, osteomyelitis, leukemia, trauma, and syphilis must also be considered. The last four are usually associated with some degree of bone destruction, whereas in the first four diseases the underlying bone is left radiologically intact. Newborn periosteal reaction. Pediatric Radiology. School of Medicine, University of Virginia. https://www.med.virginia.edu/courses/rads/peds/ms_webpages/ms6nperson.html www.med.virginia.edu/courses/rads/peds/ms6nperson.html. Accessed on September 27, 2016. VEDN, ETAL periosteal reaction with normal appearing underlying bone, a child abuse mimicker. Emergency 73, a 16-year-old boy presents with shin pain. A tibia and fibula radiograph demonstrates a well-defined, cortically based osteolytic lesion within the diaphysis measuring 4 cm craniocaudally without periosteal reaction. On MRI, the lesion is solitary, intermediate signal on T1 sequences, same as muscle, and high signal on T2. There is homogeneous and avid enhancement post-contrast administration. There is no soft tissue mass associated with the bony lesions. Chapter 11. Test paper 6, questions. 318. Which one of Emergency Radiol. 2002, 9, 5-278-82. 73. Adamantinoma. Adamantinoma appears as a well-circumscribed, slightly expansile lesion, usually with a narrow zone of transition, a finding consistent with its indolent nature. It is often multilocular, with sclerosis and lysis seen in a soap bubble pattern. The lesion is typically oriented longitudinally along the anterior tibial diaphysis, with an average length of 10 cm. MR imaging is the best modality for delineating the extent of adamantinoma in the medullary cavity, soft tissues, and satellite lesions. These tumors typically demonstrate intermediate signal intensity relative to muscle on T1, weighted images, and intensity similar to that of fat on T2, weighted images obtained without fat saturation. Static enhanced images demonstrate intense homogeneous enhancement within the lesion. Camp MD, ETAL best cases from the AFIP, adamantinoma of the tibia and fibula with cytogenetic analysis. Radiographics. 2008, 28, for 12-15-20. 74. Ground glass and solid components to the nodule. A variety of the following differential diagnoses is the most likely. A. Simple bone cyst. B. Non-ossifying fibroma. C. Fibrous cortical defect. D. Chondroid myxoid fibroma. E. Adamantinoma. 74. A 73-year-old man is found to have a pulmonary nodule on routine chest radiograph. Pre- and post-contrast enhanced CT of the chest is performed. Which one of the following features is least suggestive of benignity of the nodule? A. Nodule enhancement of 10 Hounsfield units. B. A peripheral rim of enhancement. C. A flattened configuration of the nodule. D. Central calcification. E. Ground glass and solid components to the nodule. 75. A 24-year-old man is investigated for weight loss and chronic abdominal pain. Small bowel MRI demonstrates thickened loops of small bowel. Small bowel follow-through confirms the presence of non-stenotic ulcers of the distal small bowel. Variety of features of solitary pulmonary nodules suggest a benign etiology. If computed tomography scans have been performed pre- and post-contrast administration, assessment of the degree of enhancement can be performed. Enhancement of less than 15 Hounsfield units strongly. Chapter 12. Test paper 6, answers. 350. Favors benignity, whereas enhancement of greater than 15 Hounsfield units could represent malignancy or an inflammatory process. A peripheral rim of enhancement implies benignity, but can occur with cavitating tumors such as squamous cell carcinoma. A flattened nodule, axial, craniocaudal diameter ratio of 1.78:1, is also indicative of a benign etiology, as is central calcification. Partly solid nodules, i.e. solid and ground glass components, are more likely to represent malignancy, in particular bronchialoalveolar cell carcinoma. Carcinoma. Pretorius E.S., Solomon J.A. Radiology Secrets, 2nd ed. Philadelphia, PA, Elsevier Mosby, 2006:5068. 75. A. Small bowel. Apart from Crohn's disease, which one of the following is the most common diagnosis? A. Yersinia. B. Tuberculosis. C. Reiter syndrome. D. Lymphoma. E. Steroids. 76. A 30-year-old woman with dysmenorrhea and menorrhagia has had uterine Yersinia enterocolytica is the most common cause of non-stenotic ulcers of the small bowel. It is a gram-negative organism that causes fever, right iliac fossa pain, and diarrhea. It most commonly affects the terminal ileum. As a human pathogen, Y. enterocolytica is most frequently associated with acute diarrhea, terminal ileitis, mesenteric lymphadenitis, and pseudoappendicitis. It may be complicated by abscess formation and has been associated with reactive arthritis. Tuberculosis and lymphoma are also differential diagnoses, however they are less common than ursinile infection. Occasionally, they can only be differentiated by direct visualization and biopsy rather than by imaging characteristics. Dannert W. Radiology Review Manual, 7th ed. Philadelphia, Pa, Lippincott Williams and Wilkins, 2011:7967. Con ZZ, ETAL Yersinia enterocolytica. emedicine.medscape.com/article/232343-overview accessed on February 22, 2017. 76. C. Detachment of a large submucosal fibroid following embolization. Uterine artery embolization is an increasingly popular treatment that is used for the treatment of troublesome uterine fibroids, however complications have been reported. Uterine artery embolization of her fibroid uterus. She presents with lower abdominal pain and a malodorous vaginal discharge. Ultrasound demonstrates a distended debris and fluid-filled uterine cavity with a separate hypoechoic large mass noted at the internal cervical OS, causing cervical obstruction. Which of the following is the most likely explanation for these findings? A. Embolization and subsequent swelling surrounding a cervical fibroid. B. Detachment of a large subserosal pedunculated fibroid following embolization. C. Detachment of a large submucosal fibroid following embolization. D. Incidental large endometrial polyp close to the internal cervical OSE, cervical carcinoma. 77. A 20-year-old fibroid passage is one such complication. This is defined as detachment of the treated uterine fibroid. An increased risk of fibroid passage is seen in fibroids abutting the endometrial cavity, e.g. submucosal fibroids. Fibroid passage can precipitate severe pain, infection, or recurrent bleeding. In this case, fibroid passage has caused cervical obstruction and pyometra. Cervical carcinoma and a large endometrial polyp can both cause cervical stenosis and consequent pyometra, but they are both much less likely in this circumstance. Kitamura Y. ETAL imaging manifestations of complications associated with uterine artery embolization. Radiographics. 2005, 25. 20-year-old man was seen in the A&E department after an injury to his foot during a football game. On examination, there was tenderness on palpation in the forefoot. A plain film performed showed a step in the alignment of the medial aspect of the second metatarsal bone and middle cuneiform bone. The second to fourth metatarsal had moved laterally. Normal alignment was noted at the articulation between the first metatarsal and medial cuneiform bone. Which type of fracture is demonstrated on the plain film? A. March fracture. B. Jones fracture. C. Lover's fracture. D. Homolateral least front fracture dislocation. E. Divergent least front fracture dislocation. 25. S. 1129 30. 32. 77. D. Homolateral least front fracture dislocation. Least front injury is a fracture dislocation of the tarsometatarsal joints in a dorsolateral direction. The second metatarsal is held in a mortise formed by the medial and lateral cuneiform bones. Bones. Transverse metatarsal. Metatarsal ligaments, both on the plantar and dorsal surfaces, connect the second to fifth metatarsals proximally. There is no transverse ligament between the first and second metatarsal. The plantar ligaments are stronger, hence most dislocations occur dorsally. If there is medial dislocation of the first metatarsal and lateral dislocation of the remaining metatarsals, it is considered a divergent type of least front injury. If the alignment of the first metatarsal is normal, or if it displaces laterally along with the remaining metatarsals, it is considered the homolateral type. On AP radiography of the foot, the medial aspect of the second metatarsal and middle cuneiform bone should align, and on the oblique view, the medial aspect of the third metatarsal and the lateral cuneiform bone should align. March fracture is another name for stress fracture, which commonly occurs at the distal shafts of the second and third metatarsals. They may appear on plain radiograph as a lucent line or Their presence may be noted secondary to faint periosteal reaction or callus formation. If not visible on plain films and clinical suspicion persists, MRI or radionuclide scan may be helpful. Chapter 12. Test paper 6, answers. 351. Lover's fracture is another term for fracture of the calcaneus. Jones fracture occurs in the proximal shaft of the fifth metatarsal. It has a high rate of non-union, and is found within 1.5 centimeters of the fifth metatarsal tuberosity. Dannert W., Radiology Review Manual, 6 N. Philadelphia, Pa, Lippincott Williams and Wilkins, 2007. 78. C. Tornwald cyst or pharyngeal bursa is an epithelial cyst that is related to the embryogenesis of the notochord. The incidence. Dislocation. 78. A 20-year-old patient presents with long-standing halitosis and foul taste in the mouth. MRI showed a 1.5 centimeters smoothly marginate midline cystic mass in the posterior roof of the nasopharynx, which does not enhance with contrast. What is the likely diagnosis? A. Fossa of Rosenmuller tumor. B. Rathke's pouch. Chapter 11. Test paper 6, questions. 319. C. Thornwald cyst D. Mucus retention cyst E. Chronic sinus disease. 79. Floating tooth sign is not associated with which one of the following conditions? A. Leukemia. B. Multiple myeloma. C. Multifocal histiocytosis. D. Burkitt lymphoma. E. Metastasis. Incidence of Tornwald cysts has been reported in 4% of autopsy specimens, and from 0.2% to 5% on MR observation. They occur in the posterior wall of the nasopharynx. Although Tornwald cysts are present in all age groups, the peak incidences have been reported to occur in various age groups. The three major symptoms are persistent, noticeable nasal discharge, obstinate occipital headaches, and halitosis, and an unpleasant taste in the mouth. According to researchers who have used MR imaging to study Tornwald cyst, this lesion has characteristic high signal intensity on T1 weighted and T2 weighted images. Ikushima I. ETAL MR imaging of Tornwald cysts. AJR AMJ Rentgenol. 1999, 172:1663 5. 5. 79. Metastasis multifocal histiocytosis has a triad. Only 10% of patients of Calvreal lesion. Exophthalmos and diabetes insipidus. About 40% of patients with Hand-Schiller-Christian disease, multifocal histiocytosis, have destructive lesions affecting the alveolar margins on the mandible. The surrounding radiolucent matrix gives the appearance of floating teeth. Other conditions such as leukemia, multiple myeloma, and Burkitt lymphoma can also give the appearance of floating teeth. Metastasis can cause focal or diffuse sclerotic lesions, and does not give the appearance of floating teeth. Cush KD, ETAL. The significance of floating teeth in children. Radiology. 1966, 86, 2215 19. Metastasis. 80. A 40-year-old man is diagnosed on the basis of a screening chest radiograph and a subsequent high-resolution thoracic CT scan with alveolar microlithiasis. Which one of the following is not an expected finding in this condition? A. Raised serum calcium levels. B. Diffuse involvement of both lungs. C. Intense uptake on bone scintigraphy. D. Submillimeter micronodulations. E. Marked discrepancy between radiograph and clinical. 19. 80. A. Raised serum calcium levels. The etiology of alveolar microlithiasis is uncertain, and the condition is characterized by multiple tiny intraalveolar opacities known as calcospheroids. The peak age of those affected is 30-50 years, although onset is at a young age, with antenatal onset having been reported. On biochemical profiling, serum calcium and phosphate levels are both normal. There is diffuse involvement of both lungs by submillimeter micronodulations. Uptake on bone scintigraphy is intense. The majority of patients are asymptomatic, although shortness of breath on exertion, cyanosis, and digital clubbing may be present. Lungs may appear more dense than the heart shadow on a chest radiograph, and radiographic features are disproportionate to the degree of symptoms. Dannert W. Radiology Review Manual 7. Clinical symptoms. 81, a 42-year-old patient who has a long history of ileocolic Crohn's disease presents with weight loss and vomiting. On CT, there is a heterogeneous soft tissue polypoidal mass halfway along the second part of the duodenum. No significant lymphadenopathy is noted. Which of the following is the most likely diagnosis? Seventh N. Philadelphia, Pa, Lippincott, Williams and Wilkins, 2011:470. 81, a adenocarcinoma of the small bowel Crohn's disease is a risk factor. Factor for the development of small bowel tumors, including lymphoma and small bowel adenocarcinoma. Lymphoma, however, is usually associated with lymphadenopathy and rarely involves the duodenum, being more common in the ileum or stomach. It is also more commonly extraluminal. In contrast, adenocarcinoma is most commonly intraluminal. Hamartoma-2 polyps are benign polyps usually associated with Peutz-Jeghers syndrome, which is also a risk factor for small bowel adenocarcinoma. Gastrointestinal stromal tumors are usually extramural exophytic masses. Pancreatic carcinoma is not usually associated with Crohn's disease, but could cause a bulky tumor mass in this region, although it should arise from the pancreas and invade the duodenum. Dannert W. Radiology Review Manual, 7th ed. Diagnosis. A. Adenocarcinoma of the small bowel. B. Hamartoma-2 polyp. C. Lymphoma. D. Gastrointestinal stromal tumor. GIST. E. Pancreatic carcinoma. 82. Routine mammograms of a woman show a 1 cm retroareolar lesion. Ultrasound demonstrates an 8 mm retroareolar lesion. Lesion with a dilated duct. Which of the following is the most likely diagnosis? A. Papillomatosis. B. Ductal cancer. C. Ductal ectasia. D. Plasma cell mastitis. E. Papilloma. 82. E. Papillomas are benign lesions, hyperplastic epithelium on a stalk, usually found in an ectatic subareolar major duct. They are the most common cause of blood or serous discharge. Papillomatosis refers to multiple peripheral papillomas that are located in the duct lumen just proximal to the lobule. It carries an increased risk of malignancy. Ductal ectasia is a benign entity that represents accumulation of cellular debris in enlarged subareolar ducts. Presentation is usually with non-bloody discharge and slash or pain. It is the second most common cause of blood or serous discharge. Plasma cell mastitis refers to an inflammatory component associated with extensive secretory calcification. Weiss letter R. ETAL. 83. A 57-year-old woman presents with a dry mouth and dry eyes. Ultrasound of the parotids demonstrates multiple small hypoechoic areas. MRI demonstrates a speckled honeycomb appearance on T2W images. What is the most likely diagnosis? A. Sarcoid. B. Pleomorphic adenoma. C. Sjogren's syndrome. D. Warthin's tumor. E. Mucoepidermoid carcinoma. 84. Secretory calcification. Weiss letter R. ETAL Primer of Diagnostic Imaging, 4th ed. Philadelphia, PA, Mosby Elsevier, 2007:752. 83. C. Sjogren's syndrome. Most high-grade mucoepidermoid carcinomas, undifferentiated carcinomas, adenocarcinomas, and squamous cell carcinomas of the major salivary glands have low to intermediate signal intensity on long repetition time images. Some malignancies, however, exhibit elevated signal intensity on T2 weighted images. Most commonly, this is seen in low-grade mucoepidermoid carcinomas, in some adenoid cystic carcinoma, and rarely in adenocarcinomas. Among benign masses that are not hyperintense on long repetition time images, Warthin's tumor, the second most common benign mass in the adult parotid gland, is often of intermediate, low or mixed signal intensity on T2 weighted images. The chronic sialadenitis, such as Sjogren disease, Mikulicz disease, also known as Sjogren type 1 or Sicca syndrome without a connective tissue disorder, and radiation sialadenitis may also appear hypointense on T2 weighted images. In most series, these exceptions account for the 25% error rate that occurs if one relies solely on signal intensity on T2 weighted images to predict. Histologic diagnosis. USM DM, ETAL major salivary gland imaging. Radiology. 2000, 216:1929. 84. Anteroposterior radiograph of the knee of a A 14-year-old boy shows proximal tibial physial widening and irregularity. Because of continued knee pain worsening with activity, MR imaging is performed to exclude a meniscal tear. MRI shows substantial widening and irregularity of the proximal tibial physis. Physial stress injury is diagnosed. All of the following are expected findings, except A. Cartilage injury. B. Tongue of high signal extending into metaphysis. C. Bone bridging. Chapter 11. Test paper 6, questions. 320. D. Physial irregularity. E. Diffuse low T1W signal to the bone adjacent to the physis. 29. 84. A. Cartilage injury. Conventional radiographs demonstrate physial widening, irregularity, and fragmentation. MR imaging can be used to further characterize the injury by demonstrating edema in the adjacent bone on T2, weighted or stir-mister images, and focal extensions of unmineralis cartilage into the metaphysis, which appear as tongues of high signal intensity on T2, weighted, stir and gradient called echo, GRE, images, and as intermediate signal intensity on T1, weighted images. Continued overuse leads to further physial widening, irregularity, and occasionally bone bridging. Jamie C. ETAL taking the stress out of evaluating stress injuries in children. Radiographics. 2012, 32, 25, 37, 55. 85. D. 85. A 50-year-old man with chronic middle ear problems has a CT scan of the temporal bones, which shows a cholesteatoma. Regarding cholesteatoma, which of the following statements is false? A. Cholesteatomas can be classified as either congenital or acquired. B. Congenital cholesteatomas can be located everywhere in the temporal bone. C. Primary acquired cholesteatomas develop behind an apparently intact tympanic membrane. D. Pars flaccida, attic, cholesteatomas are located at the lower 1/3 portion of the tympanic membrane. E. Pars tensa is sinus, cholesteatomas develop most often through a defect of the lower 2/3 portion of the tympanic. Pars flaccida, attic, cholesteatomas are located at the lower 1/3 portion of the tympanic membrane. Cholesteatomas can be classified as either congenital or acquired, though the origins are indistinguishable with histology and imaging. Only the location of the lesion, the clinical history of the patient, and the otologic status of the tympanic membrane trademark give some idea how to differentiate these two types of cholesteatomas. Congenital cholesteatomas develop from embryonic epithelial rests and can be located anywhere in the temporal bone, in the middle ear, in the mastoid, in the petrous apex, in the squama of the temporal bone, within the trademark, or in the external auditory canal (EAC). Furthermore, the same histologic entity can arise in other areas of the skull, in the extracranial soft tissues, or in an intracranial extraaxial location, where it is referred to as epidermoid cyst. Middle ear congenital cholesteatomas represent approximately 2% of all middle ear cholesteatomas. Primary acquired cholesteatomas, 80% of all middle ear cholesteatomas, develop behind an apparently intact trademark, usually in the region of the pars flaccida. Chapter 12. Test paper 6, answers. 353. Secondary acquired cholesteatomas, 18% of all middle ear cholesteatomas, grow into the middle ear through a perforated trademark, usually through the pars tensa, and sometimes the pars flaccida. Pars flaccida, attic, cholesteatomas are located at the upper one-third portion of the trademark. Pars tensa, sinus, cholesteatomas develop most often through a defect of the lower two-thirds portion of the trademark. Barrett K., ETAL Neuroradiology of Cholesteatomas. AJNR AMJ Neuroradiol. 2011, 32:2219. Tympanic membrane. 86, a 45-year-old woman is diagnosed with a biopsy-proven cancer. A lymph node is also demonstrated in the upper outer quadrant of the breast. Which of the following features is most suggestive of malignancy in the node? A. Hyperechoic center B, round and hypoechoic node C, posterior acoustic shadowing D. A 1.5 cm node in the upper outer quadrant E, homogeneous enhancement on MRI. '86 B, round and hypoechoic node US criteria for benign versus malignant nodes. Benign malignant. B mode scan criteria size small large greater than 1 cm/1.5 cm short axis diameter SAD. Size is a poor predictor. On its own shape oval round hilum present absent echogenicity ISO to slightly hypomarkedly hypomargins focal cortical nodules absent present intranodal necrosis absent present reticulation. '87 a 56-year-old man presents with reticulation absent present calcification absent present matting absent present. Doppler criteria flow absent present vessel location central peripheral vascular pedicle single multiple vascular. Vessel location central peripheral vascular pedicle single multiple vascular pattern regular chaotic impedance values low high. Duty with dyspnea. Chest radiography shows increased interstitial markings with a predominantly lower zone distribution bilaterally. A diagnosis of interstitial fibrosis is made on high-resolution CT. Which of the following conditions is least likely to show interstitial fibrosis with this distribution? A. Systemic lupus erythematosus. B. Rheumatoid arthritis. C. Ankylosing spondylitis. D. Methotrexate-induced fibrosis. E. Scleroderma. Dudia SM, ETAL ultrasonography of superficial lymph nodes, benign versus malignant. Med Ultrason. 2012, 14, 4294 306. 87. C. Ankylosing spondylitis ventilation in the lungs is better in the upper zones than in the lower zones. By contrast, perfusion is better in the lower zones than in the upper zones. Accordingly, there is a tendency for occupational dust exposure to cause interstitial fibrosis with a predominantly upper zone distribution, although asbestosis is a notable exception, with a lower zone distribution. Ankylosing spondylitis also has an upper zone distribution. Lower zone fibrosis tends to arise as a result of hematogenous factors. Hence, drug-induced fibrosis, e.g. that caused by methotrexate, and collagen vascular diseases, such as systemic lupus erythematosus, rheumatoid arthritis, and scleroderma, show lower zone predominance. Idiopathic pulmonary fibrosis is the most common cause of lower zone interstitial fibrosis. Pretorius E.S., Solomon J.A. Radiology Secrets, 2nd ed. Philadelphia, Pa, Elsevier Mosby, 2006:5 1727. '88, a 60-year-old man with neurofibromatosis type 1 presents with vague abdominal pain and bloating. A CT scan reveals a well-defined hyperenhancing rounded exophytic mass within the left upper quadrant, which has a broad base with the body of the stomach with no fat plane between the two. The spleen, transverse colon, and left kidney are displaced by this mass. It measures 18 centimeters. There is no lymphadenopathy. Which of the following is the most likely diagnosis? A. Ectopic pancreas. B. Gastric lipoma. C. Gastric adenocarcinoma. D. Malignant GIST, gastrointestinal stromal tumor. E. Benign GIST, gastrointestinal stromal. 27. 88. D. Malignant GIST, gastrointestinal stromal tumor. Gastrointestinal stromal tumors are the most common mesenchymal tumors of the gastrointestinal tract. They are usually found around the stomach and are often exophytic in nature. Commonly, they are found incidentally and can become very large before causing symptoms. These are difficult to distinguish from leiomyomas, leiomyosarcomas, schwannomas, and neurofibromas radiologically, and are characterized on immunohistochemistry by their Chapter 12. Test Paper 6. Answers. 354. Expression of the KIT gene. It is important to appropriately identify GISTs, as these can be treated successfully with tyrosine kinase inhibitors, Gleevec registered trademark. Gastrointestinal stromal tumors can metastasize to the liver and peritoneum, but lymphadenopathy is very uncommon. Once these tumors are over 5 centimeters, malignancy becomes more likely. Lymphoma would usually be associated with lymphadenopathy. A gastric adenocarcinoma of this size would also be likely to have associated lymphadenopathy. Gastric lipoma should not enhance and be of low attenuation. Ectopic pancreas is usually endoluminal with an ill-defined border and is more often found in the antrum of the stomach and duodenum. Dannert W. Radiology Review Manual, 7th ed. Philadelphia, Pa, Lippincott Williams and Wilkins, 2011:850. Stromal tumor. 89. With regard to ossification centers of the elbow in a child, which of the following statements is correct? A. The absence of the internal epicondyle ossification center suggests an avulsion injury, if the radial ossification center is visible. B. The absence of the lateral epicondyle ossification center could be normal in a 12-year-old. C. The trochlear ossification center occurs before the capitellum ossification center. D. Lateral epicondyle avulsion injuries are more common than medial epicondyle avulsion injuries. E. Medial epicondyle avulsion injuries are associated with excess forces from the common extensor tendon. Chapter 11. 853-4. Kim H.C., ETAL gastrointestinal stromal tumors of the stomach. Perfusion is better in the lower zones than in the upper zones. Accordingly, there is a tendency for occupational dust. Kim H.C., ETAL ectopic pancreas, CT findings with emphasis on differentiation from small gastrointestinal stromal tumor and leiomyoma. Radiology. 2009, 252:92-100. Weissletter R., ETAL primer of diagnostic imaging, 4th ed. Philadelphia, Pa, Mosby Elsevier, 2007:177. 89. B. The absence of the lateral epicondyle ossification center is often a normal finding in a 12-year-old. The ossification centers occur in order of appearance according to the commonly recited mnemonic critocapitellum, radial, internal medial epicondyle, trochlear, olecranon, and external lateral epicondyle. Although the associated age groups are commonly stated as 1, 3, 5, 7, 9, and 11 years of age, respectively, there is actually some variability, particularly as the final ossification centers appear. As such, the lateral epicondyle ossification center may not appear until age 13. Medial epicondyle avulsion injuries are far more common than lateral epicondyle avulsion injuries. The common extensor tendon inserts onto the lateral epicondyle and the common flexor tendons insert onto the medial epicondyle. Dannert double. With regard to physical stress injury in children, all of the following statements are true, except A. Little leaguer's shoulder refers to injury of the proximal humerus. B. Physical injuries are more easily identified on MRI. C. Gymnast's wrist refers to injury to the distal radius. D. Gymnast's wrist results in negative ulnar variance. E. Little leaguer's elbow refers to injury to the medial epicondyle of the humerus. 91. A 34-year-old man is undergoing W. Radiology Review Manual, 6th ed. Philadelphia, Pa, Lippincott, Williams and Wilkins, 2007. 90. D. Gymnast's wrist results in negative ulnar variance in little leaguer's shoulder. Excessive overhead throwing leads to widening and irregularity of the proximal humeral physis on radiographs and Mr. images. In gymnast's wrist, repetitive weight bearing on the wrist can lead to physical stress changes of the distal portion of the radius and occasionally the ulna. Abnormal distal radial growth produces positive ulnar variance. At a later stage, this could be associated with injury to the TFC complex. The valgus stress of the cocking and acceleration phases of pitching results in a traction injury to the medial epicondyle that is known as little leaguer's elbow. MR imaging is more sensitive than conventional radiography for detecting physical changes. Jamie C. ETAL taking the stress out of evaluating Preoperative assessment of his mitral valve using CT angiography. Which of the following combinations represents the optimal view and timing for visualizing the mitral valve on CT? A. 2-chamber view in mid-systole B. 2-chamber view in mid-diastole C. 3-chamber view in mid-systole D. 3-chamber view in mid-diastole E. 4-chamber view in mid-diastole. Evaluating stress injuries in children. Radiographics. 2012, 32, 25, 37, 55. 91, B. 2-chamber view in mid-diastole in cardiac CT imaging. Standard views include the 4-chamber, both atria and ventricles, 3-chamber, left ventricle and atrium and aortic root, 2-chamber, left atrium and ventricle, and short-axis projection views. 5-chamber views, both atria and ventricles and aortic root, can also be used. These views are usually formulated using maximal intensity projection technique on source images, with 2-chamber, 3-chamber, and 4-chamber views obtained by rotating the imaging plane along the left ventricle's long axis. Combinations A through E will all demonstrate the mitral valve, but the 2-chamber view taken in mid-diastole is the optimal view and timing for the assessment of the mitral valve. Chen J.J., ETAL CT and angiography of the cardiac valves, normal, disease. Disease and postoperative appearances. Radiographics. 2009, 29:1393 for 12. Halpern E.J. Clinical cardiac CT. Mid-diastole. 92, a 43-year-old diabetic man underwent non-contrast CT of his abdomen and pelvis, which demonstrated a dense liver. He described erectile dysfunction and arthropathy mainly affecting his second and third metacarpophalangeal joints bilaterally, but also affecting his hips. Which of the following is the most likely diagnosis? A. Amyloidosis B. Glycogen storage disease C. Wilson disease D. Hemophilia E. Hemochromatosis. (92) E. Hemochromatosis. The patient is likely to have undetected hemochromatosis. The dense liver will be caused by iron deposition, and this would give a low signal on T2, weighted, especially T2*, magnetic resonance images. Deposition in the pancreas and gonads can cause diabetes, erectile dysfunction, and hypogonadism, respectively. Hemochromatosis is often termed bronze diabetes, as there is hyperpigmentation in the skin because of the deposition of iron. It is known to cause osteoarthritic changes at many joints because of iron deposition, and the most characteristic place for this to occur is the metacarpophalangeal joints, especially the second and third, where there may also be hook-like osteophytes. Amyloidosis. Amyloidosis causes a decrease in the liver density. Wilson disease can give a dense liver and is associated with arthropathy, although this is usually of the large joints and spine. It does not cause diabetes and more often causes neuropsychiatric complaints. Hemophilia would tend to present as an arthropathy first involving multiple joints and at a younger age. The dense liver may be caused by repeated blood transfusions, but is less likely to be associated with diabetes in this case. Gaucher disease, the most common glycogen storage disease, tends to present earlier in life, although late cases are not unheard of. They tend to present with splenomegaly, lytic bone lesions, and hematological upset. Chapman S. Nachialny R. Aids to radiological differential diagnosis. Diagnosis, 4th ed. London, Saunders Elsevier, 2003, 297:555-6. Georgiades C.S., ETAL amyloidosis, review and CT manifestations. Hemochromatosis. 93, a 50-year-old woman presents with refractory hypertension and palpitations. Urinary vanillomandylic acid, VMA, levels are raised. A CT scan demonstrates normal adrenals. Which of the following should be the next line of investigation? A. Ultrasound, US, scan of adrenal glands. B. In-phase and out-of-phase MRI sequences to assess fatty content. C. Radionuclide imaging using an analog of guanethidine, such as methylionobenzylguanidine, MIBG. D. Adrenal biopsy. E. Radionuclide imaging using radio-labeled analogs of cholesterol, such as 131I6B iodomethyl, 19. Radiographics. 2004, 24:40516. 16. Weissletter R. ETAL Primer of Diagnostic Imaging, 4th ed. Philadelphia, PA, Mosby Elsevier, 2007:214. 93. C. Radionuclide imaging using an analog of guanethidine, such as methylionobenzylguanidine, MIBG. An MIBG scan will help evaluate an extraadrenal paraganglioma. Radionuclide imaging using an analog of guanethidine, such as MIBG, is concentrated in sympathoadrenal tissue, and is thus used to image adrenal medullary disorders. Adam A. ETAL Granger and Allison's Diagnostic Radiology, a textbook of medical imaging, 5th ed. New York, Churchill Livingstone, 2008. Iodomethyl, 19, norcholesterol, NP, 59. 94. A 65-year-old male patient presents with back pain and loss of sensation in his left leg. An MRI scan of his lumbar spine reveals multiple lesions within the vertebral bodies of his lower spine, of varying sizes. These were of low signal on both T1 and T2 sequences. Which of the following is the most likely diagnosis? A. Myeloma B. Paget disease C. Prostate cancer metastases D. Renal cancer metastases E. Hemangiomas. (1723:1729:30). 94. C. Prostate cancer metastases to bone are 100 times more common than primary skeletal neoplasms, and are found at sites of dominant hematopoietic marrows because of its rich hematopoietic marrow. In adults, this includes the calvarium, spine, flat bones, and proximal humeral and femoral metaphyses. Focal sclerotic lesions are hypointense on T1 and T2 weighted sequences. The most common metastases in adult men are due to prostate carcinoma. Renal metastases are usually lytic. Hemangiomas are hyperintense on both T1 and T2 weighted sequences. Dannert W. Radiology Review Manual, 7th ed. Philadelphia, PA, Lippincott Williams and Wilkins, 2011. Hemangiomas. 95. A 40-year-old woman with long-standing history of epistaxis has been diagnosed with Wegener's granulomatosis. The following statements are true about Wegener's granulomatosis affecting the head and neck except A. It may lead to destruction of the hard palate. B. Premaxillary and retroantral fat are rarely involved. C. Sarcoidosis may have a similar appearance. Chapter 11. Test paper 6. Questions. 322. D. Chronic disease may result in thickening of the paranasal sinuses. E. The nasal septum may disappear in chronic disease. 2011. 95. B. Premaxillary and retroantral fat are rarely involved. The combination of necrotizing granulomatous lesions of the upper and lower respiratory tracts, generalized necrotizing vasculitis of arteries and veins, and glomerulonephritis is called granulomatosis and polyangiitis, previously called Wegener's granulomatosis. The disease may affect the eyes, skin, joints, muscles, and cardiac system as well as the paranasal sinuses, lungs, and kidneys. Advanced Wegener's granulomatosis may lead to destructive lesions of the hard palate, sinonasal oral fistulas, or complete nasal septal destruction. The premaxillary soft tissues, retroantral fat, pterygopalatin fossa, infratemporal fossa, and orbits are commonly involved. Sarcoidosis may have a similar appearance. When a destructive mass in the nasal septum extends into the orbits, Wegener's granulomatosis should be considered in the differential diagnosis. Intracranial involvement may also result, usually, in the anterior cranial fossa, owing to the spread of the disease through the cribriform plate. Chapter 12. Test paper 6. Answers. 356. As the disease becomes chronic, the walls of the residual paranasal sinuses, particularly the maxillary sinuses, become markedly thickened while the sinus volume is gradually reduced, and the nasal septum may completely disappear. Valencia MP, Castillo M, Congenital and Acquired Lesions of the Nasal Septum, A Practical Guide for Differential Diagnosis. Radiographics. 2008, 28:20523. 96. D. Absence of drop metastases on MRI spine imaging. The description would fit with a medulloblastoma. Drop metastases are commonly found at presentation, and complete imaging of the neuraxis is strongly recommended at diagnosis. Cerebrospinal fluid, CSF, seeding. Disease. 96. A large posterior fossa mass arising from the roof of the fourth ventricle is identified on an MRI brain in an 8-year-old child. The lesion is poorly defined and does not contain any internal calcification or extension into the basal cisterns. Which imaging feature of this lesion would be considered atypical? A. Marked associated hydrocephalus. B. Avid contrast enhancement. C. Hyperdense appearance on CTD. Absence of drop metastases on MRI spine imaging. E. Restricted diffusion on diffusion-weighted imaging. DW. Seeding, with the resultant formation of spinal intradural drop metastases. DWI. '97. A preterm neonate born at 24 weeks is referred for a cranial ultrasound study. A focus of increased echogenicity is present in the right caudothalamic groove extending into the lateral ventricle without ventricular dilatation. Which grade germinal matrix? Matrix hemorrhage with this feature most represent A. Grade 1B, Grade 2 center Grade 3D, Grade 4E, Grade 5. 98. A 50-year-old teacher with a neck lump is referred for an ultrasound, which revealed a thyroid nodule. Which of the following is an indication for FNA of a thyroid nodule? A. Entirely cystic lesion. B. Presence of microcalcification. C. Presence of multiple cystic nodules. D. Every nodule above 2 centimeters. E. Every nodule that is hypervascular. Drop Metastases. SR Med J, 2008, 98, 7522-3. 97. B. Grade 2. The most common location for injury to the premature brain is the periventricular white matter, with ischemic parenchyma manifesting as periventricular locomalacia, PVL. Initial sonograms show hyperechogenic globular change in the periventricular regions, and MR images depict areas of T1 hyperintensity within larger areas of T2 hyperintensity. Subsequent cavitation and periventricular cyst formation, features that are required for a definitive diagnosis of PVL, develop to 6 weeks after injury and are easily seen on sonograms as localized anechoic or hypoechoic lesions. The progressive change ventricular dilatation occurs, described as end-stage PVL. Subsequent reperfusion to the ischemic tissues in the setting of weakened capillaries and increased venous pressure result in germinal matrix hemorrhage, ranging in severity from subependymal hemorrhage, grade 1, to intraventricular hemorrhage without grade 2, and with grade 3, ventricular dilatation, to parenchymal extension and coexisting periventricular. Venous infarction, grade 4. Chow CP, ETAL neonatal hypoxic ischemic encephalopathy, multimodality imaging findings. Radiographics. 2006, 26, Supple 1 S15972. 98. B. Presence of microcalcification. These are general recommendations for adult patients who have a thyroid nodule on US images, regardless of how the nodule was initially detected. The recommendations may not apply to all patients, including those who have historical, physical or any other features suggesting they are at increased risk for cancer, or who have a history of thyroid cancer. Part I. The following are general recommendations for nodules 1 cm or greater in largest diameter. Solitary nodule. Strongly consider FNA for 1. A nodule 1 cm or more in largest diameter if microcalcifications are present, and 2. A nodule 1.5 cm or more in largest diameter if any of the following apply. 8. Nodule is solid or almost entirely solid, or B. There are coarse calcifications within the nodule. Chapter 12. Test paper 6. Answers. 357. Consider FNA for 1. A nodule 2.0 cm or more in largest diameter if any of the following apply. 8. The nodule is mixed solid and cystic, or B. The nodule is almost entirely cystic with a solid neural component, or 2. The nodule has shown substantial growth since prior US examination. FNA is likely unnecessary if the nodule is almost entirely cystic, in the absence of the above listed features. Multiple nodules. Consider FNA of 1 or more nodules, with selection priority on the basis of the previously stated criteria in the order listed above. FNA is likely unnecessary in diffusely enlarged glands with multiple nodules of similar US appearance without intervening normal parenchyma. Note that these recommendations are not absolute or inflexible. In certain circumstances, the physician's clinical judgment may lead him or her to determine that FNA need not be performed for nodules that meet the recommendations above. In others, FNA may be appropriate for nodules that do not meet the criteria listed above. Part 2. The recommendation for non-diagnostic aspirates from initial FNA is as follows. Consider a second FNA of nodules meeting the criteria for FNA of solitary nodules as outlined above. Part 3. The presence of abnormal lymph nodes overrides the US features criteria and should prompt biopsy of the lymph node and / or if necessary, of an ipsilateral thyroid nodule. Freights MC, ETAL Management of Thyroid Nodules Detected at US Society of Radiologists Ultrasound Consensus Conference Statement. Radiology. 2005, 237:794-800. Hypervascular. 99. A 62-year-old man is found to have a right-sided pleural effusion on imaging. Which of the following pathologies is more likely to result in a pleural effusion on the right side than on the left side? A. Transection of the proximal thoracic duct. B. Traumatic rupture of the thoracic aorta, distal to left subclavian artery. C. Spontaneous esophageal rupture. D. Gastric carcinoma. E. Pancreatitis 100. A 26-year-old diabetic 'Diabetic man who is known to binge drink is referred to you with deranged liver function tests following antibiotics for a chest infection. On ultrasound, you see a hyperechoic area anteriorly within the left lobe of liver within segment 4. Which of the MRI sequences from the list below will be the most helpful in determining the nature of this lesion, although all would be required for a definitive diagnosis? A. In-phase and out-of-phase T1, weighted images. B. T1 and T2W images. C. Diffusion-weighted images, and apparent diffusion coefficient. D. Dynamic contrast enhanced phase images. E. T2 with T of 80 milliseconds and T2 with T of 160 milliseconds. A. Transection of the proximal thoracic duct. Disruption of the thoracic duct results in a chylothorax. The thoracic duct measures 45 centimeters and commences at the level of T1-2, ascending on the right side of the aorta, crossing the midline at the level of T5, and ascending in the left hemithorax to drain into the confluence of the left subclavian and internal jugular veins. Accordingly, disruption of the proximal thoracic duct results in a right-sided pleural effusion, and disruption of the distal thoracic duct causes a left-sided pleural effusion. Dissecting aneurysm of the thoracic aorta and traumatic rupture of the aorta both result in left-sided effusions, as does spontaneous esophageal rupture, Barr-Haff syndrome, and gastric carcinoma. Pancreatitis can give rise to bilateral or unilateral pleural effusions, with more than two-thirds of pancreatitis-related effusions occurring on the left. Dannert W. Radiology Review Manual, 7th ed. Philadelphia, Pa, Lippincott, Williams and Wilkins, 2011:445. 100A. In-phase and out-of-phase T1, weighted images. The hyperechoic area seen on ultrasound anteriorly within segment 4 is most commonly caused by focal fatty infiltration, and is a common finding at ultrasound, and is more common in heavy drinkers, hypolipidemia, and in obese patients. It is also commonly seen at the portal bifurcation. Although all of the above sequences will be important in accurately defining the lesion, the most useful sequence when this is likely to be focal fatty infiltration will be the in-phase and out-of-phase T1 weighted images. Focal fat should lose signal between the in-phase T1 weighted images and the out-of-phase T1 weighted images. Middleton W.D., ETAL ultrasound, the requisites, 2nd ed. St. Louis, M.O., Mosby, 2004. Sohn J., ETAL unusual patterns of hepatic steatosis caused by the local effect of insulin revealed on chemical shift MR imaging. AJR AMJ Rentgenol. 2001, 176:471-4. Chapter 12. Test paper 6, answers. 160 milliseconds. 101. When investigating adrenal disease, which of the following statements is incorrect? A. Biochemical evaluation is usually the first line of investigation. B. Delayed radiolabeled analogs of cholesterol, such as 1-6B, iodomethyl, 19, not cholesterol, NP, 59, are used to identify and localize masses that result in adrenocortical dysfunction. Chapter 11. Test paper 6, questions. 323. C. MIBG, an analog of guanethidine, is used to image adrenocortical disorders. D. 131I and 123I, MIBG, can be used to screen the whole body for sympathomedullary tissue. E. 18F fluorodeoxyglucose, FDG, can sometimes differentiate between benign adenomas and metastases. 102. A20. (358). 101. C. MIBG, an analog of guanethidine, is used to image adrenocortical disorders. All the statements are correct except option C. MIBG, an analog of guanethidine, is used to image adrenomedullary disorders. 18F FDG has been reported to be able to differentiate between benign adenomas and metastases. Adam A. E. (102). A 20-year-old male patient presents to the A&E department following a skateboard injury. He has pain in his right clavicle and plain films are subsequently performed, which reveal elevation of the clavicle above the superior border of the acromion. What statement is true in regard to this injury? A. The acromioclavicular, AC, ligament is ruptured but the coracocclavicular, CC, ligament is intact. B. The joint capsule is ruptured but the CC ligament is intact. C. The CC ligament is ruptured but the AC ligament is intact. D. The AC ligament, CC ligament and joint capsule are ruptured but the deltoid attachment is intact. E. The AC ligament and CC ligament are ruptured with detachment of the deltoid muscle. E.T.A.L. Granger and Allison's Diagnostic Radiology, a textbook of medical imaging, 5th ed. New York, Churchill Livingstone, 2008, 1723:1729-30. 102. E. The AC ligament and CC ligament are ruptured with detachment of the deltoid muscle. The Rockwood classification is used to classify ACJ injuries. Lifting of the clavicle above the superior border of the acromion implies a severe strain injury with typical complete derangement of the internal attachments and stabilizing structures, grade 3 injury. Grade 4/6 injuries also imply the same degree of soft tissue injuries, but there is accompanying complete dislocation with the clavicle displacing into various positions. Grade I injuries have an intact CC with AC ligament strain. Grade 2 injuries, elevation of the clavicle but not above the superior border of the acromion, have a ruptured AC ligament and joint capsule, with strain of the CC ligament. Rockwood CA, ETAL acromioclavicular injuries. In Rockwood CA, ETAL, EDS fractures in adults, 4th ed. Vol I, Philadelphia, Pa, Lippincott Raven, 1996:1341-413. 103. D. 103. You are reporting a CT pulmonary angiogram of 39-year-old man who presented with shortness of breath. You have excluded pulmonary embolism, but are concerned about the appearances of the trachea, which has diffuse narrowing of the lumen with marked wall thickening. You decided to contact the A&E clinician to clarify patient symptoms. After further questioning, the patient admits to episodes of wheeze and stridor for over past few months. All of the following cause diffuse thickening of the wall with decreased diameter of the tracheal lumen, except A. Relapsing polychondritis, B. Tracheopathic Osteoplastic, C. Tracheal Wegener's granulomatosis, D. Meunier-Kuhn disease, E. Tracheal sarcoidosis. D. Meunier-Kuhn disease. Tracheobronchomegaly, known as Meunier-Kuhn disease, is a rare condition, usually affecting men in the 4th and 5th decade of life. It is characterized by marked dilatation of the trachea and bronchi. Patients typically present with recurrent respiratory infections and bronchitis. It is caused by atrophy and dysplasia of the tracheal wall, and the tracheal diameter is usually more than 3 centimeters. Tracheopathic Osteoplastica is a rare benign disease affecting the trachea and characterized by multiple submucosal osteocartilaginous growths within the anterior and lateral walls. This condition, as the others listed above, relapsing polychondritis, tracheal Wegener's granulomatosis, tracheal sarcoidosis, cause significant narrowing of the tracheal diameter with wall thickening and symptoms of stridor, wheeze, cough, and dyspnea. Kwong J.S., ETAL diseases of the trachea and main stem bronchi, correlation of CT with pathologic findings. Radiographics. 1992, 12:645-57. Weiss letter R, ETAL primer of diagnostic imaging, 4th ed. Philadelphia, Pa, Mosby Elsevier, 2007:49. Sarcoidosis. 104. A patient presents with deranged liver function tests, right upper quadrant pain, nausea, flushing and recurrent bouts of diarrhea. The surgeon thinks the patient may have gallstone disease and requests a MRCP. A single 3 mm gallstone is noted within the gallbladder, but the bile ducts are within normal limits. A markedly hyperintense lesion on T2 is noted within the mesentery, and a few of the small bowel loops in this region appear tethered. The lesion enhances avidly following administration of gadolinium. There are further hyperintense lesions noted throughout the liver, which also avidly enhance in the arterial phase. Which one of the following is the most likely diagnosis? A. Metastatic melanoma, B. Cholangiocarcinoma with liver and mesenteric metastasis, C. Retractile mesenteritis, D. Carcinoid syndrome, E. Cholecystitis with mesenteric and liver abscesses. 49. 104. D. Carcinoid syndrome. Carcinoid syndrome is a collection of symptoms that are caused by a small proportion of carcinoid tumors. This nearly always occurs following metastasis to the liver, although it can happen if a carcinoid tumor occurs outside the gut and its excreted chemicals, adrenocorticotropic hormone, histamine, serotonin, etc., bypass liver metabolism. These chemicals cause recurrent diarrhea, bronchospasm, flushing, and right-sided heart failure. A spiculated mesenteric mass with calcification and a desmoplastic effect on the adjacent bowel in a patient with these symptoms is characteristic of carcinoid syndrome. These tumors are often hyperintense on T2, weighted magnetic resonance imaging, as they are very vascular. They also produce hypervascular metastases. If there is carcinoid syndrome, the carcinoid tumor is usually located in small bowel. Malignant melanomas are often bright on T1 and do not usually give a desmoplastic mesenteric reaction or give flushing. Cholangiocarcinomas produce hypervascular liver metastases, but mesenteric deposits are unusual and the biliary tree appeared normal in this case. Retractile mesenteritis would not cause liver lesions. Mesenteric abscesses from cholecystitis would be rare, and only the rim should enhance with gadolinium. This condition would also not be expected to produce a desmoplastic reaction. Bader TR, ETAL MRI of carcinoid tumors, spectrum of appearances in the gastrointestinal tract and liver. J. Man Rezan Imag. 2001, 14:261-9. Chapter 12. (105) An adult patient undergoes ultrasound examination of the abdomen. He is known to have end-stage renal failure and has been on renal dialysis for 5 years. Incidentally, several round and well-defined anechoic lesions are demonstrated in both kidneys. These demonstrate posterior acoustic enhancement. There is no previous relevant family history, and a previous ultrasound 5 years ago was normal. Which of the following is the most likely diagnosis? A. Adult polycystic kidney disease. B. Multicystic dysplastic kidney. C. Multiple simple renal cysts. Chapter 11. Test paper 6. Questions. 324. D. Cystic renal cell cancer. E. Uremic cystic disease. Dannert W. Radiology Review Manual, 7th ed. Philadelphia, Pa, Lippincott Williams and Wilkins, 2011:826-8. Horton K.M., ETAL carcinoid tumors of the small bowel, a multi-technique imaging approach. AJR AMJ Rentgenol. 2004, 182:55967. Weiss letter R, ETAL Primer of Diagnostic Imaging, 4th ed. Philadelphia, PA, Mosby Elsevier, 2007:191. 105, uremic cystic disease. About 40% of patients with end-stage renal disease develop renal cysts. The incidence increases with time on dialysis, so that incidence of uremic cystic disease is 90% in patients 5 years on dialysis. Associated complications include hemorrhage within the cysts and rarely malignancy. Cysts regress after successful transplantation. 106, an 80-year-old patient with history of rheumatoid arthritis has been involved in a 40 miles per hour head-on car crash. Airbags were deployed. You are asked to review a cervical spine trauma series. No fracture is identified. The patient has mid-cervical spine tenderness. The patient wants to go home. Which of the following is the best option? Option A. Let the patient be discharged since trauma series is normal. B. Repeat lateral and AP views. C. Request a flexion and extension lateral cervical spine. D. Cervical spine CT. E. Bone scintigraphy. Weiss letter R, ETAL Primer of Diagnostic Imaging, 4th ed. Philadelphia, PA, Mosby Elsevier, 2007:289. 106, D. Cervical spine CT. In high-risk patients or patients with limited physical examination, given the relative insensitivity of plain films, CT should be performed. In a rheumatoid patient there is an increased risk of cervical injury. Repeat views would not be of benefit. Age and mechanism of injury would indicate CT cervical spine according to NICE guidelines. Blackmore CC, ETAL cervical spine screening with CT in trauma patients, a cost-effective analysis. Radiology. 1999, 212:11725. Head injury, assessment and early management. Management. NICE guidelines, CG176, https://www.nice.org. 107. All of the following statements are true with regard to stress fractures in young athletic children, except A. A. Children with limb misalignment are at greater risk. B. Stress fracture of the femoral neck involves the superior surface. C. Shin splints show linear edema limited to the medial tibia. D. Distal femoral metaphysis are recognized sites for stress fracture. E. Pars interarticularis fractures are due to repetitive extension and torsion. https://www.nice.org.uk guidance/CG176, accessed on February 22, 2017. 107. B. Stress fracture of the femoral neck involves the superior surface. Surface. The most common cause of stress fractures is a chronic and repeated workload. Children with extremity malalignment or abnormal weight bearing also are at increased risk. Typical locations of stress fractures in children include the tibia, fibula, femur, and tarsal and metatarsal bones. MR imaging is currently the best diagnostic modality for stress fractures. Stress fractures of the femur tend to occur after skeletal maturity and resemble adult injuries, affecting the inferior surface of the neck, the shaft, and the distal metaphysis. This injury is most common in endurance athletes, such as runners, triathletes, or soccer players, but also occurs in association with abnormal weight bearing, such as with a coxavar deformity. The most common site for stress fractures in the adolescent athlete is the tibia. Tibial stress fractures occur with activities requiring sudden stops or changes in direction, such as football, soccer, and tennis. Stress also can result in shin splints, which are probably an early stress response secondary to periosteal traction. In cases of stress fractures, MR imaging shows diffuse and irregular bone marrow edema, whereas in shin splints, the area of high signal intensity often is more linear and is limited to the medial aspect of the tibia. Spondylolysis is a stress injury of the pars interarticularis that is due to repetitive extension and torsion of the trunk. Usually occurring in the lower segments of the lumbar spine, stress injuries of the pars interarticularis have been observed in young female gymnasts, college football players, and wrestlers. Jamie C. ETAL taking the stress out of evaluating stress injuries in children. Radiographics. 2012, 32, 25, 37, 55. 108. A 7-year-old boy presents to his emergency department complaining of a limp and pain in his left hip. He is febrile and blood test results reveal raised inflammatory markers. The emergency department staff are concerned regarding an underlying diagnosis of septic arthritis. Which one of the following statements regarding imaging in septic arthritis is false? A. An ultrasonography can be performed to guide needle aspiration of an underlying hip effusion. B. Destruction of underlying bone is normally seen at presentation on plain radiography. C. The suggestion of underlying hip effusion may be identified on plain radiography of the pelvis. D. An effusion normally collects in the anterior recess of the hip joint on ultrasound early in the process. E. Septic arthritis is usually a monoarticular process. 109. 108. B. Destruction of underlying bone is normally seen at presentation on plain radiography. If joint inflammation is limited to a single joint, infection must first be carefully excluded. The cause of septic arthritis is usually related to hematogenous seeding owing to staphylococcal or streptococcal microorganisms. The radiographic features of a septic joint encompass those of any inflammatory arthritis, namely periarticular osteopenia, uniform joint space narrowing, soft tissue swelling, and bone erosions. Not all findings may be present simultaneously, and acutely, bone erosions may not be. Chapter 12. Test paper 6, answers. 360. Evident. Furthermore, the joint space may be initially widened owing to the effusion. Joint space widening may also be seen with more indolent and atypical infections, such as those related to tuberculosis and fungal agents. The Femister triad describes these findings classically seen in tuberculous arthritis, juxtaarticular osteopenia, peripheral bone erosions, and gradual narrowing of the joint space. The presence of anterior capsular distension was noted as convexity of the anterior recess, and compared to contralateral normal side in equivocal cases. Bhargava S. Bhargava SK, infective arthritis of hip, role of sonography. Jimsa. 2013, 26, 115-16. Jacobson J.A., ETAL radiographic evaluation of arthritis. 109, a 42-year-old female patient with shortness of breath undergoes CT pulmonary angiogram for suspected pulmonary embolism, PE. In addition to the presence of subsegmental PE, the scan reveals two well-defined, rounded intraluminal polypoid masses on the posterior wall of the trachea and multiple small nodules in both lungs. Disseminated malignancy is suspected. Which primary malignancy is most likely to metastasize to the trachea? A. Malignant melanoma. B. Ovarian carcinoma. C. Sarcoma. D. Transitional cell carcinoma of the urinary bladder. E. Pancreatic carcinoma. Arthritis, inflammatory conditions. Radiology. 2008, 248, 2378, 89. 109. A. Malignant melanoma. About 90% of all tracheal tumors are malignant, and of those metastases are the most common group. Malignant melanoma, renal cell tumor, breast carcinoma, and colonic adenocarcinoma are the most common sources of hematogenous metastatic spread to the tracheal mucosa. The lesions are usually multiple, polypoid, well-defined, and without tracheal wall thickening or extratracheal extension, as commonly seen in primary tracheal tumors. Cancers of the thyroid, esophagus, larynx, and lung may invade the tracheal wall by direct extension from the primary source, and this type of spread is the most common in secondary tracheal malignancies. The symptoms of tracheal malignancies are nonspecific and include hemoptysis, dyspnea, chest pain, cough, and wheeze. Dannert W., Radiology Review Manual, 7th ed. Ed. Philadelphia, Pa, Lippincott, Williams, and Wilkins, 2011:455. (110) A middle-aged woman presents with a painful anterior neck lump associated with a rash. Ultrasound of the thyroid demonstrates an enlarged hypoechoic and hypervascular gland. Follow-up imaging for months later shows resolution of the previous changes. What is the diagnosis? A. Hashimoto's thyroiditis. B. De Quervain's thyroiditis. C. Multinodular goiter. Chapter 11. Test paper 6. Questions. 325. D. Papillary thyroid carcinoma. E. Anaplastic carcinoma. (110) A. Hashimoto thyroiditis. Hashimoto thyroiditis, also known as chronic autoimmune lymphocytic thyroiditis, is a disease with a typical clinical presentation of painless diffuse enlargement of the thyroid gland accompanied by hypothyroidism and thyroid autoantibodies. The sonographic appearance of Hashimoto thyroiditis is well recognized. The gland is often diffusely enlarged, and the parenchyma is coarsened, hypoechoic, and often hypervascular. A micronodular pattern on ultrasound is highly diagnostic of Hashimoto thyroiditis with a positive predictive value of 95%. Discrete nodules may, however, also occur within diffusely altered parenchyma or within sonographically normal parenchyma. The nodular form of Hashimoto thyroiditis has not received nearly as much analysis as the diffuse form, and the reported findings have been variable. Anderson L. ETAL Hashimoto thyroiditis, Part 1, sonographic analysis of the nodular form of carcinoma. 111. A 72-year-old woman with B12 deficiency and achlorhydria has a barium meal. The stomach is featureless with no demonstrable rugal folds, and there is narrowing of the body of the stomach. Which of the following is the most likely diagnosis? A. Infectious gastritis. B. Menetrier disease. C. Eosinophilic gastritis. D. Atrophic gastritis. E. Laminitis plastica. Form of Hashimoto thyroiditis. AJR-AMJ Rentgenol. 2010, 195:20815. 111. D. Atrophic gastritis. Atrophic gastritis has a high association with B12 deficiency. It occurs in the older population and is often caused by autoimmune disease. However, it can also be caused by Helicobacter pylori, leading to chronic inflammation of the gastric mucosa and eventually fibrosis. Atrophic gastritis particularly affects the chief and parietal cells, resulting in achlorhydria and B12 deficiency, and causes the classic featureless stomach. It is associated with an increased risk of gastric carcinoma. Infectious gastritis, Menetrier disease, and eosinophilic gastritis are often associated with thickened folds. Laminitis plastica would have a history of weight loss and iron deficiency anemia, as opposed to B12 deficiency. Adam A. ETAL Granger and Allison's Diagnostic Radiology, a textbook of medical imaging, 5th ed. New York, Churchill. Plastica. 112. A 26-year-old obese and unwell woman attends the A&E department with right-sided abdominal pain. She has a positive pregnancy test. The A&E doctor requests an abdominal and pelvic ultrasound, which demonstrates some fluid within Morrison's pouch. The pelvic area is not well demonstrated on transabdominal ultrasound due to the patient's obesity, but no intrauterine pregnancy is noted. Which of the following should happen next? A. Laparotomy. B. CT of the abdomen and pelvis. C. Transvaginal ultrasound. D. MRI of the pelvis. E. Laparoscopy. Livingstone, 2008:635-7. 112. C. Transvaginal ultrasound. This patient has a suspected ectopic pregnancy, which is a potentially fatal gynecological emergency. Transvaginal ultrasound, TVUS, can detect intrauterine pregnancy 1 week sooner than transabdominal ultrasound, TAS. If no intrauterine pregnancy, IUP, is seen on TAS, you should therefore confirm that there is no IUP by TVUS where possible. The free fluid in this case is. Chapter 12. Test paper 6. Answers. 361. The result of a ruptured bleeding tube secondary to an ectopic pregnancy, the fluid may be echogenic because of blood content. TVUS is preferable to CT, as the patient may have a viable early pregnancy. In hospitals where TVUS is not available, emergency laparoscopy may be considered. However, MRI is not a safe environment for a potentially unstable patient. Chapman S., Nachialny R., Aids to Radiological Differential Diagnosis, 4th N. London, Saunders Elsevier, 2003:496. Danner. Laparoscopy. 113. Which one of the following is not a radiographic hallmark of degenerative arthritis? A. Asymmetrical joint space narrowing. B. Subchondral sclerosis. C. Periarticular osteoporosis. D. Subchondral cysts. E. Osteophytes. Danner W. Radiology Review Manual, 7th N. Philadelphia, Pa, Lippincott Williams and Wilkins, 2011:1054-5. 113. C. Periarticular osteoporosis. Degenerative arthritis and osteoarthritis are interchangeable terms that can be used to describe the clinical and radiographic joint changes associated with aging. Early changes include damage to the articular cartilage with progressive damage to and loss of the ground substance that eventually leads to the subchondral bone being exposed. Clinically, patients present with joint pain worsened with use, and the joint may be found on examination to be enlarged, deformed, tender with crepitus, and possibly display joint effusion. The 5 radiographic hallmarks are asymmetrical joint space narrowing, subchondral sclerosis, subchondral cysts, osteophytes, and lack of osteoporosis. Osteophytes. 114. A 30-year-old teacher presents with thyroid swelling and proptoses. Which of the following is true regarding Graves' ophthalmopathy? A. It commonly involves the medial rectus first. B. It commonly involves the tendons of the eye muscles. C. There is associated dilatation of the superior ophthalmic vein. D. There is decreased density of the orbital fat. Osteoporosis. Periarticular osteoporosis is much more characteristic of rheumatoid arthritis. Weiss letter R. ETAL Primer of Diagnostic Imaging, 4th N. Philadelphia, Pa, Mosby Elsevier, 2007:452. 114. C. There is associated dilatation of the superior ophthalmic vein. Graves' disease of the orbit is also known as thyroid ophthalmopathy or endocrine exophthalmos. It is produced by long-acting thyroid-stimulating hormone, probably due to cross-reactivity against antigens shared by thyroid and orbital tissue. Signs and symptoms usually develop within 1 year of hyperparathyroidism. It is the most common cause of unilateral/bilateral proptoses in adults. It commonly involves the inferior rectus first, mnemonic I'm slow. The superior ophthalmic vein is dilated due to compromised orbital venous drainage at the orbital apex. There is increased density of the orbital fat late in the disease. Danner W. B. It commonly involves the tendons of the eye muscles. C. There is associated dilatation of the superior ophthalmic vein. D. There is decreased density of the orbital fat. E. It is an autoimmune disease unrelated to thyroid function. 115. A 78-year-old man presents with weight loss and frank hematuria. He had a stricture of his urethra dilated many years ago. He has no other relevant past history. Initial ultrasound and IVU show a normal upper urinary tract and bladder. As part of the standard workup, he proceeds to flexible cystoscopy, but the urologist is unable to pass the cystoscope beyond the proximal penile urethra. He is therefore referred for an ascending urethrogram, which demonstrates an irregular filling defect in the bulbar urethra. Which of the following is the likeliest diagnosis? A. Prostatic carcinoma. B. Transitional cell carcinoma of the urethra. C. Squamous cell carcinoma of the urethra. D. Adenocarcinoma of the urethra. E. Recurrent benign stricture. Radiology Review Manual, 7th N. Philadelphia, Pa, Lippincott Williams and Wilkins, 2011:3489. 115. C. Squamous cell carcinoma of the urethra. Primary urethral carcinoma is rare. About 50%-75% occur in the bulbar urethra, and nearly 90% are squamous type, particularly if there has been a stricture in the past. Urethral carcinoma is often advanced at diagnosis, explaining the weight loss. Primary transitional cell carcinomas, TCC, are closer to the bladder neck, although secondary TCCs can occur anywhere in the urethra when seeded from the bladder in patients with a bladder TCC history. When they are often multiple, these are the most commonly encountered male urethral tumors. Adenocarcinomas are extremely rare and tend to occur at the prostatic utricle or glands of Litra. Hematogenous metastases to the urethra are exceedingly rare but are most likely to be from melanoma. Prostatic carcinoma would be more likely to involve the prostatic urethra. Benign strictures can appear a little irregular, but weight loss would not be expected. Lynch D. Carcinoma of the urethra. American Medical Network. http://www.health.am/c/urethral-carcinoma. http://www. 116. A 34-year-old patient with a recent history of a prolonged stay in an intensive care unit following road traffic accident is referred to the respiratory clinic with symptoms of dyspnea, expiratory wheeze and recurrent chest infections. A CT scan of the chest is performed. Chapter 11. Test paper 6. Questions. 326. Which one of the following is the most likely tracheal complication of the previous prolonged intubation in this patient? A. Carrot-shaped trachea. B. Saber-sheath trachea. C. Tracheomalacia. D. Tracheopathic Osteoplastic. E. Tracheal diverticulum. http://www.health.am/c/urethral-carcinoma, accessed on February 24, 2017. Weiss letter R. ETAL Primer of Diagnostic Imaging, 4th N. Philadelphia, Pa, Mosby Elsevier, 2007:31819. 116. C. Tracheomalacia. Weakening of the tracheal walls associated with posterior tracheal wall collapse during expiration is a recognized complication post-intubation and tracheal tube placement when the cuff pressures exceed 25 cm/H2O. This condition is often underdiagnosed as it can present with nonspecific symptoms such as shortness of breath, wheeze, stridor, and recurrent chest infections. Dynamic CT scan during inspirational and expirational phases is the modality of choice for its diagnosis, and it is considered positive when the AP diameter of the trachea decreases more than 50% during expiration. Tracheomalacia may also be a complication of chronic obstructive pulmonary disease, COPD, relapsing polychondritis, and recurrent infections. Tracheal diverticulum and saber-sheath trachea, decreased coronal diameter of trachea, are conditions associated with COPD, and carrot-shaped trachea refers to a narrowing of the tracheal diameter in the caudal direction as a result of an aberrant left pulmonary artery. Webb M. ETAL. Using CT to diagnose non-neoplastic tracheal abnormalities, appearance of the tracheal wall. AJR AMJ Rentgenol. 2000, 174:1315. Diverticulum. 117. You are performing a small bowel follow-through on a 42-year-old female patient because of abdominal pain, weight loss, and anemia. The patient has had a normal endoscopy and colonoscopy. There is separation of the ileal loops within the right side of the abdomen. Some of the ileal loops in this region appear compressed on one side, and one of the loops appears aneurysmal. You also note the presence of a fistula between the distal ileum and colon. Except for these ileal loops, the remainder of the small bowel appears normal. Which one of the following is the most likely diagnosis? A. Crohn's disease. B. Tuberculosis. C. Small bowel lymphoma. D. Metastatic serosal deposits. E. Celiac disease. 13-15-21. Weiss letter R. ETAL Primer of Diagnostic Imaging. 4th ed. Philadelphia. Pa. Mosby Elsevier. 2007:107. 117. C. Small bowel lymphoma. Small bowel lymphoma is a soft pliable tumor and therefore can often be quite large in size without causing a bowel obstruction. Characteristically, it destroys Auerbach's plexus, leading to aneurysmal dilatation of the small bowel. However, this is a rare finding. It often fistulates, mimicking Crohn's disease, but there would be more likely to be skip lesions with Crohn's disease. Tuberculosis can have similar appearance, but these patients will often be from an endemic area or have HIV. Fever and night sweats will also be more prominent, although these symptoms can also occur in lymphoma. Adam A. ETAL Granger and Allison's Diagnostic Radiology. (118) A 65-year-old man presents with pain, swelling, and paresthesia in his left thigh. Clinical examination revealed a large 10 × 6 cm soft tissue mass within the left thigh. The mass is of soft tissue density on CT and demonstrates avid contrast enhancement. There is no involvement of the adjacent bone. On MRI, the mass returns a predominantly low signal on T1W sequences and high signal on T2W sequences. Which of the following is the most likely diagnosis? A. Lipoma. B. Liposarcoma. C. Osteosarcoma. D. Soft tissue fibroma. E. Lipoblastoma. Churchill Livingstone, 2008:668-9. N and MKN, ETAL Gastrointestinal Tuberculosis. emedicine.medscape.com/article/37601-overview accessed on February 24, 2017. Dannert W., Radiology Review Manual, 7th ed. Philadelphia, Pa, Lippincott Williams and Wilkins, 2011:867. 118. B. Liposarcoma. Liposarcoma is a malignant tumor of mesenchymal origin. It is the second most common soft tissue sarcoma in adults after malignant fibrous histiocytoma, now called pleomorphic undifferentiated sarcoma or pus. It usually presents in the 5th to 6th decade. On CT, it is seen as a non-specific soft tissue mass, as the fat content is usually not radiologically detectable. On MRI, because of the high content of myxoid cells, the most common type of liposarcoma, it is low signal on T1 weighted sequences and high signal on T2 weighted sequences. A lipoma would not be expected to enhance post-contrast. A large lymph node would be unlikely to reach the sizes described and additionally may be hyperintense to muscle on T1 weighted sequences. A soft tissue fibroma would have a small hypointense nodule on all sequences. Lipoblastoma usually affects children less than 3 years of age. Dannert W., Radiology Review Manual, 7th ed. Philadelphia, Pa, Lippincott Williams and Wilkins, 2011. Kronsdorf M.J., ETAL Imaging of Fatty Tumors, Distinction of Lipoma, and Well-Differentiated Liposarcoma. Radiology. 2002, 224:99-104. 119, D. The beta angle can... 119. On a routine neonatal birth check, the pediatric registrar suspects an infant of having developmental dysplasia of the hip, DDH, and refers the him for a hip ultrasound. Which one of the following statements regarding hip ultrasound according to the graph classification is correct? A. A normal alpha angle is less than or equal to 60 degrees. B. A normal beta angle is greater than 20 degrees. C. The alpha angle is measured from the triangular labral fiber cartilage to the vertical cortex of the ileum. D. The beta angle can help to determine the dysplasia subtype. E. The acetabular angle is measured from the acetabular roof to the vertical cortex of the ileum. 100. Can help to determine the dysplasia subtype. The graph method for ultrasound classification system for developmental dysplasia of the hip, DDH, in infants combines both the alpha and beta angles. The alpha angle is formed by the acetabular roof to the vertical cortex of the ileum. The normal value is greater than or equal to 60 degrees. Less than 60 degrees suggests acetabular dysplasia. The beta angle is defined as the angle formed between the vertical cortex of the ileum and the triangular labral fiber cartilage, echogenic triangle. There is a great deal of variability in the beta angle and is not universally used. Chapter 12. Test paper 6, answers. 363. The beta angle is necessary to determine the subtype of hip dysplasia. Acetabular angle is a radiographic assessment for dysplasia. It is formed by a horizontal line connecting both triradiate cartilages, Hilgen-Rainer line, and a second line which extends along the acetabular roofs. Graph R, ETAL Hip Sonography, Diagnosis and Management of Infant Hip Dysplasia. Berlin, Springer-Verlag, 2006. 120. CT of the head of a young man for chronic headache showed erosion of the left frontal sinus. Post-contrast showed focal meningeal enhancement with mucosal enhancement of the right frontal sinus. What is the most likely diagnosis? A. Mucocele. B. Inverted papilloma. C. Pott's puffy tumor. D. Anthracoanal polyp. E. HIV. Chapter 11. Test paper 6, questions. 320. 120. C. Pott's puffy tumor. Pott's puffy tumor is defined as a subperiosteal abscess of the frontal bone with frontal osteomyelitis. Frontal sinus infection can spread directly through the thin bone wall of the sinus or through the network of small veins that drain its mucosa. Today, this is a rare complication, given the widespread use of antibiotics. Trauma and frontal sinusitis are the most common causes of this condition. The bacteria causing Pott's puffy tumor usually reflect the type of bacterial species responsible for community-acquired chronic sinusitis. The most common causal organisms are streptococci, staphylococci, and anaerobic bacteria. Cultures frequently reveal polymicrobial involvement. The infection may spread as a thrombophlebitis from the frontal sinus through the diploic veins, involving the intracranial space with consequent epidural or subdural empyema, meningitis, brain abscess, and venous sinus thrombosis. More on FA, ETAL lumps and bumps on the head in children, use of CT, and MR imaging in solving the clinical diagnostic dilemma. Radiographic. 2004, 20 for 16 55 74. Chapter 12. Test paper 6, answers.